Truly are the. Right, I'm going to share my screen and we're just going to let people slowly join us for the next minute, and then we'll get started in about a minute. Welcome to those who are joining us. This is such a great time of day to do presentations and webinars and such that are national in scope, because you can just say good afternoon and it hits afternoon for our friends in British Columbia and our friends in Atlantic Canada. All right, let's get started. We have an hour together today. Welcome to the National Safer Supply Community Practices monthly research spotlight webinar. My name is Rebecca Penn, and I'm an uninvited settler, currently living in Mi'kma'ki, which is the traditional and ancestral territory, and also the contemporary and ongoing unceded territory of the Mi'kmaq people. So I'm the project manager of the National Safer Supply Community of Practice, and I'm really pleased to welcome you all here today. We have Dr. Carol Strike joining us from the Dalai Lama School of Public Health at University of Toronto. And Carol is here to talk about some exciting research findings. But before we launch into our presentation for today, I'd like to have us start with acknowledging colonialism and its role in our day-to-day lives, both in our present as well as in our past. So we're coming together today from across what is now known as Canada, from different places across Turtle Island. We are people who live on treaty lands and unceded territories. We work in a sector whose goal is to address harms, social harms, and we must recognize that the production of these harms comes from the history of colonialism and its enduring practices, institutions, and ways of thinking. Colonialism is with us today, and we must commit to working together in ways that reshape these institutions and practices to repair harms, to prevent future harms, and to work towards a more inclusive and just future. I'd like to invite you to use the chat box. You can introduce yourself and identify where you're joining us from, and acknowledge the lands that you are living in and benefiting from. I also want to acknowledge today is Black Balloon Day. So Black Balloon Day is a day for us to recognize and celebrate those who have lost their lives to substance use related harms. And the goal of doing this is to honor lives lost, as well as raise awareness about the stark realities of the drug poisoning crisis that affects people across Canada. So one of the things that you can do is, if you use social media, you can put an image of a black balloon in your social media. And we'd invite you to use tags, including Black Balloon Day 2023, Moms Stop the Harm, Overdose Awareness Manitoba, Overdose Awareness Edmonton. Those are the groups that are really pushing this campaign, that have organized this national campaign. And yes, they're inviting you to participate. So for some of you joining us today, you're members of the community of practice, and it's great to have you here. We're also welcoming people who are not necessarily all that familiar with the community of practice. So just allow me a minute or two to tell you about who we are. So we are funded by Health Canada Substance Use and Addictions Program, and we're a collaborative that operates between the London Intercommunity Health Centre, the Canadian Association of People Who Use Drugs, and the Alliance for Healthier Communities. Our mandate is to support the scale-up of safer supply programs through capacity building and knowledge exchange. And our current focus is on a medical model of safer supply, so that's prescribed safer supply. And the reason for this is at this moment in time, it is the most feasible from a legislative and regulatory perspective. But we also support the discussion and advocacy for other models of safer supply. and decriminalization. So I'd like to invite you to check out our website. That's where you'll find all kinds of resources that we have, including an evidence brief and protocols and guidance documents and a large library of resources. So I'll invite you to check that out. That's also where you can join the community of practice and check out our archive of our past webinars and our upcoming events. So we are recording this event and we will be sharing it on our website. If you are having technical difficulties, the best thing to do is actually just log out and then rejoin. Sometimes that takes care of all the problems. We do have closed captioning available in English. You can find that on the toolbar of Zoom. We also have the chat box where you can interact with all the attendees, as well as Dr. Strike and myself and our team. We also have a Q&A box, and this is a great place. If you have a question that you would like Dr. Strike to address, please put it in the Q&A box and we'll get to that. We do have a certificate of attendance for those who would like one. About halfway through, we'll pop a link in the chat box and you click on that link and that will take you to a form. You fill out that form and a few minutes later, you'll get a certificate of attendance in your inbox. And if you'd like to learn more about who we are and what we do check out our website. We're always interested in hearing from you as well about what would help support you in your community, scale up safer supply and care for people who use drugs. And with that, I'm really happy to pass this over to you, Carol. Thanks so much for being here, and I'll let you introduce yourself and your presentation.
Great. Thanks for the invitation. I'm really pleased to talk about some findings from our study. I'm just going to share my screen, and I just will ask once I go into presenter mode, if a question goes in the chat box, can someone just open their mic and start talking, because I won't be able to see it soon.
Okay, I'll do that, Carol.
Okay, thanks. Okay, and can you see everything okay? Rebecca?
Oh, sorry, you're in presenter mode. Sorry, you're in, we can see your notes on the side.
How about that?
Didn't you? Oh, there you go. There it is. It's perfect.
Okay. Great. So good afternoon. I'm Carol Strike. I'm a professor at the Dal Atlanta School of Public Health, and I'm also one of the investigators on this study. And I'm here presenting for the authors listed there, but also for our larger team. I just want to start by acknowledging the land from which I present today. So for thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, it is still the home to many Indigenous people from across Turtle Island. I'm a settler on this land, and my grandparents began arriving on Turtle Island in the early 1900s. I'm deeply grateful for the opportunity to live, work, and thrive on this land. Just please join me in a moment of reflection to acknowledge the history and mistakes of the past and how to consider how we each in our own way can move forward in a spirit of reconciliation and collaboration with Indigenous peoples from across North America. I'd also like to acknowledge, before I get started on the presentation, all the participants who for sharing their stories, their personal hopes and challenges, and the candor with which they spoke to us when we collected the data for this study. I'm also deeply grateful to the sites for their help and patience with our study. We have data because they helped us in so many different ways. And I also acknowledge the funder, which is the Ontario Network of Ontario HIV Treatment Network. And I also will acknowledge, Black Balloon Day. So as I said, I'm a member of a much larger team, and these are the names of all the people on the team, and they've all contributed in their own ways. So what am I going to do today? I'm going to talk just a very small bit about the background of safer supply prescribing in Canada because of the audience that's here today. I don't need to do an extensive background at all for that. I'll talk one slide about emerging evidence about safer supply. And then I'm going to focus my time on findings from an Ontario project that was conducted in London and Toronto. And in particular, I'm going to talk about accessibility, perceived impact on injection-related risks, perceived impact on health and well-being, and perceived impact of COVID-19 on the experience and practice of safe supply prescribing. I'll talk about some key ideas coming from our analyses and some future work. So for those of you who aren't from Canada, because I think some people from outside Canada have signed up, safe supply projects have been funded by Health Canada, and that began around 2020. And when I looked on the website not too long ago, it looked like there were 25 safer opioid supply projects funded by Health Canada, and 11 of these were Ontario. And there's a link if you're interested in what Health Canada has funded and some of their other projects that they have funded as well. I just want to note that Ontario doesn't, the province where I live, doesn't fund these programs as of yet, but does pay for physician and nurse practitioner medical visit fees. So the rest of the funding comes from Health Canada. A few years ago, there were a lot of commentaries, maybe a lot is a big word. There were commentaries about the need for safer supply, and they'd existed for a while, right? Now there's data available, and it's growing. Sometimes by the day, I search for these, and these are some that came up just today, and they're from the last year, and there's more. So it's a rapidly expanding area of harm reduction literature, and our project was designed to contribute to that literature, but more importantly, to contribute to improving the safer supply programs for people receiving those services, and also for people providing the services within the program. So as I said earlier, I'm going to talk about an evaluation of 4 safer supply programs in Ontario. One was in London, Ontario, and 3 were in Toronto. What I'll also say is one of the programs had been running for quite a few years before we got there, and other programs had just started operating just before we started collecting data, which provides you some context to understand some of the data. These programs prescribe what would be called the Ontario model of safe supply, right? There's different models of safe supply, different medications, different formulations that can be prescribed. But in Ontario and the programs that we talk to, these programs were embedded in primary care and delivered by a community health center or a similar organization. They provided off-label prescriptions for take-home dilaudid, so that's hydromorphone. And most people we spoke to also got a daily observed dispense of Cadian or slow release methadone. And there was variation in within and across the programs in terms of how the medications were prescribed and also picked up. For the larger project, so this was a 2.5-year project, we were interested to understand patient experiences, like what it was like to be in the programs, how it changed their lives or didn't, what were the benefits and the challenges of being in a safer supply program. We were particularly interested in the impacts on HIV prevention and treatment, and how issues like gender and racialized identity influence the experience. And I won't talk about those today because we're still working on those, but that was an interest and part of our design. We were also interested to understand what the perspective from the physicians and the allied health, physicians, nurses, and nurse practitioners, counselors, outreach workers, and also pharmacists about what it was like to offer safe supply. And also we wanted to understand how they perceived COVID-19 affected their practice. And the same, we were interested in what pharmacists had to say. To be honest, we don't have a lot of data from pharmacists, and I won't be talking about it today because we had trouble recruiting pharmacists, even though we worked really hard to get pharmacists, but we did have some trouble there. So this is a qualitative study, and we use semi-structured interviews along with a demographic survey and a program characteristic survey that one was completed per site. We are interested in people enrolled in the programs, and as I also said, the people delivering the programs with varied roles. We collected data in person, by Zoom or telephone. It varied during the pandemic, depending on the restrictions in place. And for a while, only the investigators and none of our staff were allowed to collect data. So my colleague Adrian and I collected quite a bit of the data, not all of it, but some of it, along with our research coordinators who did a lot of the data collection on the telephone and by Zoom. And we did basic thematic analysis. We didn't do anything particularly fancy there, but we have an advisory group who has provided feedback on the coding structure and also the themes as we've gone along. To like, this is what we're hearing. What do you think? How do we understand this kind of thing? In terms of who we spoke to over 50 patients enrolled in these programs. Most identified, just over half identified as men, none identified, all identified as cisgender. We spoke to most of the patients identified as white, and some identified as Indigenous. Many of them experienced housing insecurities of different types at the time, and just about 13, just over 13% or 7 people were HIV positive when we asked them about their HIV status. We also talked to 21 service providers. We talked to nurse practitioners, we talked to physicians, system navigators, case managers, outreach workers. We talked to any service provider who was willing to talk to us. And in some of the sites, we talked to all of the service providers. Some we didn't, but I think we talked to every prescriber in all of the programs when we did this study. So in terms of findings, so like those are the people we talked to, and we are interested to understand how the programs run. And so one of the questions I want to answer for you this afternoon is like, how accessible are the programs? And we had a lot of conversations with prescribers and service providers about people getting into the programs. So they talked to us about how they decided who was going to get into the program. Because it wasn't just anybody who showed up at the door. And for some, it wasn't showing up at the door, it was phoning because they opened during COVID. So they had a set of admission priorities when they first started operating. And they changed a little bit over time, but for the most part, when we were interviewing, the admission and priorities included everybody had to be what they called refractory for opioid agonist treatment. So that's a fancy term for saying that someone had been in methadone or buprenorphine treatment or Suboxone or some kind of other treatment and had not completed it, or were no longer in it, or were in it, but perhaps still were interested in safer supply. They had to have had an experience of opioid overdose. And the programs also wanted to give priority to people identified as women, LGBTQ2+, as Black or Indigenous or another person of color, the people who were engaged in sex work, people who were homeless and or had some kind of housing insecurity, were living with unmanaged HIV or hepatitis C, and or that should say palliative for HIV, and or were pregnant. And so they had a set of criteria. Eventually it developed into a point system about who would get in or not. And so as this one nurse says, we prioritize people who had overdoses, especially recently. Another person told us when they saw that a lot of the people in the program were white and a large proportion were male, they started to try to make sure that their admission priorities set more priorities for people who were racialized, people from the LGBTQ community, women, and people with disabilities. So they talked a lot about, spending time trying to figure out what would be their priorities, how they were going to implement them. And despite having priorities that were designed to focus on those in the community who were most at risk and maybe have trouble otherwise getting into a program. There was such a huge demand, which one of them referred to as a sea of need. And these were all small programs. The one in London was much larger, but still, even for the larger programs, there was limited capacity, and the programs had a smaller staff complement, and they couldn't keep up with the demand for people trying to get admissions into the programs. So the demand quickly exceeded the available spots. Some of the practitioners talked about how, because the need so greatly exceeded the demand, they were worried about having what would be called a population impact. So that would mean, although they could have an impact on the individual patients in their practices, they were worried, could they actually have an impact on overdose rates in the community, because there were so many people in need and they didn't have enough spots. And there was also challenges in terms of resources, because the programs were small. Most of them were small, and they had no backup for sick days and vacation. So they found it, like it was quite stressful to try and get people into the program, but at the same time, not overstretch the resources that they had available at hand. The pandemic also created further struggles in trying to manage or think through how to, who was going to be enrolled and who was not going to be enrolled. COVID for a while, limited the capacity on site to see patients. And it slowed down admissions. And for some, the slowdown was so much that by the time someone's name came up on the wait list, they could no longer contact them. That created a lot of distress for people working in the programs, that they're trying to get people in and then they couldn't find them. Also, at the time, some of the people who got COVID and ended up in a COVID isolation hotel were started on safer supply. And when they left the COVID hotel, they needed to find a prescriber. And so the programs that we talked to were expected to add them to their patient population, which the programs wanted to do, but it interfered with their own wait lists and their understanding of who was going to get into the program. And so that slowed down admissions for them. They had an admission, but it slowed down the people waiting for admissions in their programs. And another thing that happened was some of the people in the program were sharing doses with their partners. And so the programs felt, obliged to admit the partners as well, which interfered with their wait lists and the like. So it was a very challenging environment, and I think it's still a challenging environment for a lot of these programs. So what did they do? They tried a point system. They tried to narrow down the point system. They had some challenges in COVID. And then some of the programs started to restrict their eligibility even more, because they had so many, very limited spots. So they restricted their eligibility to the most complex patients and those who were housing insecure. So complex means they had lots of other coexisting medical or health problems. And so what it says there, high acuity rates. So you needed more points per se, or you had to fit more of the criteria to get in. So as one person says, that we try to prioritize to be most urgent and at-risk folks, especially women that are pregnant and have a lot of recent ODs. And another physician said, and certainly people who are very marginalized, so people who continue to sleep rough, or people with health conditions like HIV, and that we really get a good handle on those. So those were the people that were getting in and had the most complicated or challenging health problems. So while that helped programs manage understanding who was going to get in and who it wasn't, who wasn't going to get in. It slowed down admissions as well because the required a longer intake process. It increased the pressure on the primary care resources that were available. So people weren't only getting their prescribed medications, right? They were also having medical tests for lots of things, being sent for referrals. They would present with lots of extra problems, and the programs were trying to help them address those issues as well, all in the context of limited staffing. And the programs talk to us about like really going above and beyond for all of their patients to try and, for some of their patients hadn't been in primary care for years. And so they'd show up with all kinds of problems, and they were trying to, meet the needs of the patients. And so by doing that, it restricted their ability to bring in some more patients because they had to kind of get people stabilized before they could, and moving on before they would have the time to bring in more people. And it was for some of them talked to us about turning away people from a harm reduction program was a new experience. For those who had worked in harm reduction for a while, they had never had that experience before, and they found it really, really distressing that they couldn't provide as care to as many people as they knew needed it. And they found that very troubling. And many of the prescribers that we talked to during our study took some kind of leave because the pressure on them was so high. So they took some kind of leave during the time that we were actually conducting our study, which tells you a little bit about the amount of pressure going on in some of these programs. So what did we learn about sort of this accessibility? So what we learned is that the demand greatly exceeds the available spots, that the providers use strategy to screen in the highest acuity clients, and they would, I should have also said, for those they didn't take in, they often provided referrals to other places where people could go, maybe not to get safe supply, but to get other services that may help them reduce their risk or improve their access to healthcare. There was a lot of moral distress and burnout for the providers, who often talked about feeling unsupported by their colleagues in the area who could add but did not or would not add safer supply to their practices. And some of them talked about making up safe supply as they go in relation to admission criteria. So changing the admission criteria they did it as a group and they talked about it, but they were worried that they didn't really have time to stop and think about the consequences per se of what they were doing. And they were quite concerned about that. So the next thing I want to talk to you about is the impact of the program. So we asked a lot of questions about, what was the impact on people. And so the first thing I'm going to look at is, do the programs have an impact on injection-related risks? So anybody in our study, and maybe some of you out there are in our study, would tell us that, safe supply had some kind of impact on drug use. Some people told us, I haven't touched fentanyl in a long time. Some people said, I don't inject my safe supply. Other people say, this one man said, I get a daily dispense. I think it's the best thing that's ever happened to me. And so what kind of patterns did we see in impact on drug use? So for some people, who once they were in the program, they talked about reducing their injecting and their fentanyl use. So mostly clients and providers talked about there was a marked decrease in the amount of fentanyl people had used. Most also reported a reduction in overdoses, but not all. Some people continued to have experiences with overdose, but many had not had an overdose since being in the program. And the providers talked about observing far fewer injection-related complications like abscesses and the like. So as one said, and then there are people that, regardless of their safe supply, are still actively overdosing. So they said that they had some impact on some people, but there needed to be some more time with some other people. And another person said, okay, I feel comfortable with this dose. I'm at that point where I'm not using fentanyl as much. So that was a client telling us. So you can kind of see the different kinds of experiences. And at the end, I'll talk to you about some of the limitations of our design and how you might understand that finding. Some people, talked about transitioning to injecting only their prescribed medications. So what that meant is they were no longer injecting anything they bought out, like from a street source. But they did continue to inject, and they slowly eliminated fentanyl use. People talked about how the slow release morphine or the quetiapine helped them to eliminate fentanyl use, and the prescribers talked about that too. And when asked, most people had a goal of eliminating injecting and maybe reducing some use at some point in time. And one said, so let me go here. I'm trying to switch the get off the needle because I think once I'm taking them orally, it'll be easier for me to wean down. So people had different goals, and it wasn't uniform. Lots of people told us they had different goals. Some people talked about, and physicians talked about it, and nurse practitioners talked about how some of their patients had switched to, they were no longer injecting at all. They were only swallowing or snorting their safe supply meds. So as it says on the slide, some immediately eliminated injection and only swallowed or snorted. Others gradually eliminated injection. And they said that getting high from this safe supply medication allowed them to eliminate the injection of other medications, which they had not been able to achieve in opioid-assisted treatment, which was something that they wanted to maintain, but they did want to reduce their risk for overdose and other related complications. And as this client said, I swallow them or I snort a couple here and there just to get that taste right away. And it seems to work. And this person, the quetiapines were particularly helpful at night. So what did we learn about impact on drug use? So most clients, well, I think every client we talked to changed their behaviors in one or more ways. While the programs were not designed to reduce injection per se, offering a safe supply led to this outcome for some of them. One thing I want to say is we're not sure, because we have a qualitative study that was conducted at a particular point in time, so we didn't follow people over time. Sometimes people told us who had been in the program for a long period of time how their use had changed over time, but because of our design, we don't know about how time in the program, length of time injecting, the types of drug used, how other comorbid mental health problems influences the patterns. And it's something that we'd like to consider in the future. And so it seems that the safe supply programs may be able to achieve what some other kinds of harm reduction programs, needle and syringe programs, or supervised consumption may not be able to achieve, because they're not designed to achieve that goal in terms of reducing injections. So just want to be clear. So I'm not saying, so don't leave here saying Strike just said we don't need needle and syringe programs or supervised consumption, because I'm not saying that at all. What I'm just saying is that safe supply programs, for some people, they stop injecting after a while, and which you might not see with other kinds of harm reduction programs. But I will also say that fear of overdose from fentanyl is also influencing people's patterns of use. So people may be showing up at the programs and they may not be injecting as much anyway when they arrive because they're so scared of using fentanyl. So the next thing, I'm just going to check my time here. Okay, talk about is, do the programs have an impact on health and well-being? So I talked about injection and drug-related risks, and now I want to talk about, or patterns of use, about health and well-being. And so the most stunning thing that I would say my colleague Adrian and I heard when we first started interviewing people on the programs was almost everybody we talked to, whether at the beginning or not far into our interview, would tell us, how the program had changed their life. We didn't ask them that. It spontaneously came out, and every single person that we talked to said that. So as the one quote says, I don't chase drugs as much anymore, and I'm not dead. And another person said, I've never had an overdose since I've been on the program. It was like really profound to hear that over and over and over again. And like totally reassuring, about a safe supply. For these people prior to the program, they had experienced repeated overdose. So this was like such a new experience for them. After the admission, many had not overdosed at all, or some did so with less frequency. And they linked the prescription drugs of known quality and dose to the change in their experience of overdose. Profound. It was like something changed the minute I started getting my prescription. And they also experienced a lot less fear and anxiety from using drugs, which they lived every single day before they got on safe supply, about like, is this going to be the day? And not knowing. People talked a lot about the impact of having a prescription on criminal activity. So before enrollment, a lot of people, were involved, not all, but a lot of them were involved in some kind of daily cycle of criminal activity. They were often incarcerated frequently, and they did what they did to get drugs and avoid withdrawal. For those with a prior history of incarceration, not everybody had been incarcerated, but vast majority had. They reported, but if they had, they reported no recent arrests. Some said, like this program, as what they were advocating it for, it costs much less than putting people in jail. Many, after they had been enrolled, started to have a new, more positive sense of self. So as one of the bottom quotes said, so this was a woman who said, I was so sick and tired of jail. And she told me that she had been in and out of jail so many times, every time she went back to prison, the guards would tell her welcome home, which is just quite heartbreaking. And since she'd been in the program, she hadn't been arrested or gone to jail once. As another person said, I used to have to go boosting every day just to get my medication. Now I don't have to do that. It's like a whole new life. If you've ever seen the TV program The Wire, there's oh my God, I've just forgotten his name. Omar. There's a character named Omar who, would walk down the street and people would scatter. And we interviewed someone like that who said, like that was his experience of his world before he was on safe supply, and people were scared of him and he knew it. And he said ever since, I shouldn't say ever since, but after he started to be on safe supply, he wasn't doing the kind of things that he had been doing in the past. And he was people were less scared of him, and he was deeply proud of that change in his life. It was profound for him. People also talked a lot about improved access to health services, and which led to improved health. We had one person who said their health wasn't any better, but everybody else told us that their health was better in some way or another. They often said they felt heard, believed, and cared for, a new experience for most who had the opposite experience in a lot of healthcare settings. They talked about their pain issues being addressed by the medications they were receiving. Reduced pain led to improved sleep and also improved mobility. And some of their long-standing health problems started to be addressed, which they hadn't in the past. So someone said, I've been pretty discriminated against in every healthcare setting I've been in, but I've never been treated that way here. And another person said, I'm in less pain all the time. They also talked about increased stability in their housing, food security, and relationships. They talked about, wasn't everybody, but a lot of people talked about having money for other things, for food, going out, buying a computer, making plans. One guy talked to us about, he was so pleased that he, maybe a woman, I forget if it was a man or woman, but being able to afford to pay for Netflix. It was like, wow, I have a Netflix subscription. Like, it's amazing, right? So such a change in my life. A few had returned to work or started to work. More were housed, but a lot of them some of them talked to us about how their housing was contingent on the COVID housing, and they worried that perhaps that that wasn't going to be maintained for them. And they were also worried about the housing affordability crisis. So, that caused a lot of distress for them, and made us wonder about, what's going to happen to some people if they lose their housing. A woman talked to us about, said, it's a dream. I have a normal life. A lot of people talk to us about, like, all of a sudden I have a hope for a future, right? Didn't have that before. Another one said, as I said, I can buy food with my money. All my money would go to drugs in the past. So people talked about having a renewed sense of self. Not everybody wasn't as dramatic as that sort of Omar guy, but they talked about, I'm slowly getting my life back on track. I feel like a person, not so shunned by society. Gives me a better outlook on life. I don't have to be ashamed, or my kids don't have to be ashamed that dad is panhandling. I can walk with my head up because I have a life. It's kind of heartbreaking. So that I should say, it's heartbreaking. That's how people had felt before. So what are some of the key ideas? Well, there seems to be a lot of improvement beyond withdrawal management and reduced overdose that people talk to us about, and prescribers also, and allied health professionals talked about as well. That access and trust within primary care seems to be helping people re-engage with health services in the programs, but also external to the programs, because the programs are providing referrals and supports in other settings. So people are getting better care, or they talked about, like, it hasn't, don't get me wrong, the environments that they're going to haven't been like completely changed, right? Outside of the safe supply programs, but people did talk about, experiencing change in other settings because their clinicians had spent some time prepping them, and also the clinicians they were going to see, and they were having a better experience. They talked a lot about this, surprise of the impact on their well-being. A lot of people didn't expect that. It's like, wow, I never expected these changes, right? The wraparound services that a lot of the programs provide seem to be essential to the improved outcomes, right? So it's the medication is the fundamental, but the wraparound services really push some of the other changes that people experience. So I'm just starting to think about, we're getting around to looking at, I know it's a bit late, but the COVID-19 and its pandemic on the clients and their programs. So these are really preliminary findings. So when we asked, what's it been like being on safe supply during the pandemic? For some people, they'd started during the pandemic. Other people had started after or before the pandemic. But a few said to us, well, I don't think there's been much change for me in terms of the impact of the pandemic on their experience of safe supply or whatever. Another one said, I don't feel like it's changed at all. Just, talked about, some of the restrictions it put in place and masking and the like. But others talked to us about that the pandemic brought program changes. So they had less frequent appointments that they had to come in for. They experienced less crowded waiting rooms, and they also perceived to have less exposure to COVID-19 risk. And they were, deeply grateful for the environments in which they were getting care. We're trying to mitigate their risks by coming into the program. So one said, doctors are more willing to dose you every week of meds and instead of having to go in every day just to make your life easier. That person points out, you don't have to be on the streetcar as much, which was a big concern in Toronto during some points of the pandemic and still today. Sometimes this woman said, sometimes you'd get here at 9 a.m. and you wouldn't be leaving till 4 o'clock in the afternoon. You'd be here all day. And that wasn't their experience during the pandemic, that their wait times were fundamentally changed. So as I said, the wait times were fundamentally changed. I just lost my thing here. Okay. There we go. So some talk to us about increased wait time outside to get into programs because of capacity limits in. So they waited outside longer. Where's the quote? There's one at the bottom right-hand corner. So the person said, it used to be a real pain in the ass because everything was closed. So I'd have to kill time outside, going to coffee shops that weren't open, or you couldn't stand in. That was a problem in wintertime. But slowly that got worked out for some over time because some of the programs went to fixed appointments as opposed to, come as you are, whenever you are, right? And people really appreciated that opportunity. Another person said, the wait times were difficult in the past because, they were often in withdrawal, and the fixed appointments helped with that. So some people talked a little bit about, maybe it was longer to wait to get in, but that once you were in, the appointments were sped up. So maybe, across the two, the wait times in general were less. The flexible appointment style was greatly appreciated. Some during the pandemic did them in person, by phone, and or online, and they varied from program to program. Occupancy limits, had a lot of influence on when people got in, or if they could get in, or if they had to be in one room and the prescriber in another room. One of the things that people talked about was they really appreciated, not all of them, but the flexibility in the appointment style, and they worried about if their appointments were going to go back to what they were before COVID. And so I'll just say, so we did these at a particular point in time, so we don't know if they went back. There was some indication as we got later in our data collection that some of the appointment schedules were going back, but not the long wait times in the waiting rooms as they had been before COVID. Some experience reduced services. So a couple of clients talked to us about, well, they used to have before COVID some services for Indigenous clients, but during the pandemic they didn't, and they missed those. But also people talked about how that when they got into the safe supply programs and the other services that they couldn't get because of COVID, they were able to get through the safer supply program. So they greatly appreciated that. People talked about having priority access to COVID-19 vaccines. They also talked about having a trusted source of information about COVID-19 at a time when there was all kinds of information going on about COVID-19. So if you look at the bottom quote, this is I cut out some of it, but this woman said, and I'd always hear these things, these rumors that would go around. And then I would go to her, meaning her prescriber, and I'd say, oh my God, is it true that if you have blonde hair, you're more likely to get COVID or something? Just stupid things I would hear. And she would quickly say, no, that's ridiculous. And this woman really appreciated that, her prescriber, one, would listen to her, and two, give her an answer. And there was kind of like no shame in asking whatever it is she wanted to know. And she wasn't the only person that talked about the importance of having someone they trusted to provide information at a time when they needed information. So what did we learn from this sort of sub-analysis? That changes to appointment modality, frequency had benefits in terms of convenience and also reduced exposure to risk. As I said, our data were collected during the pandemic and before and after mandates and capacity restrictions were in place. I know that sentence is all mucked up. I need to fix it. Sorry about that. And we're not sure what changes have been remained or reversed or the like because of the nature of our data collection. So, how am I doing for time? Okay. I just want to say a few things across all the analyses. The practice of safe supply was described to be extremely impactful and rewarding. Prescribers and others involved in the programs would say, it's like nothing else I do in primary care gets this kind of response. And they were like profoundly like amazed at what was being achieved for their patients. the primary care model seems to be pivotal for improved health and well-being. So what I said earlier is that it's more than just getting a medication, right? The additional improvements come with getting the medication, right? And the regular medication, but also the supports in place, you know, that the navigators, the counselors, the other nursing services and the like, and the referrals and the like, and helping people connect in the community. We have some, you know, thoughts and concerns about, you know, sustainability and scalability issues. These are highly resource intensive programs. They cost a lot and there's lots of human resources. And it raises some questions about, you know, scalability. But one wonders also if they were spread out across more primary care settings, what what could be achieved. And there's some evidence to show that from I forget, Young et al., that talks about the reduced healthcare costs associated with people who have been in safe supply programs. I think that study is actually from the London, not this study, but another study done in London. There seems, as I said, seems to be signs of cost savings for the healthcare system and potentially for the criminal justice system. We weren't designed to evaluate that, but you know, a lot of people told us, I'm not going to jail anymore, and so something's going on there. The prescribers and the allied health talked about, as I said, it's very rewarding and very emotionally draining. It's because of the magnitude of the need in their communities. Maybe you know, the intensity of supports each patient may lessen over time. So it's really, that kind of points to the need to study programs over time to see, like, how does this play out over, you know, someone who's been in the program for a year, 2 years or more, right? Like, what does their life look like after that? I think we're a bit concerned as a team about how the housing affordability crisis may undermine health gains in general. So that's deeply concerning. So what are we doing now? And then I'll open the floor up for some questions. So we're studying another program in Ontario that operates a safe supply program in what they call a village of services. And so they're similar to these, you know, programs that we cited, but this village of services model is quite interesting, and we hope to be presenting findings about that soon. While we were conducting this study, we were hearing a lot about changes in how fentanyl may be influencing addiction medicine. And so we're doing another study in Hamilton, and we're looking at, like, how has fentanyl impacted not only safer supply, but OAT, opioid agonist treatment. We're interested in, you know, the impact of fentanyl on enrollment, access, dispensing, and prescribing patterns, and you know, and we're also it's a COVID study too. We're interested in trying to understand how COVID may have prompted some changes in prescribing and other practices related to OAT or safer supply. And just a plug, if you happen to be a clinician in the Hamilton area and you prescribe safer supply or methadone or Suboxone, we're recruiting right now. So please send me an email. We'd love to talk to you about what it's like for you and what it has been like over the past year. So sorry for the plug, but if you're out there, please talk to us. We want to talk to you. So Rebecca and her crew are going to post a poll, and they'd really like you to complete the poll to tell us a little bit about who you are and some other things. So I'm going to do the poll as I keep talking. Oh, I can't vote. So anyway, and I will stop sharing my screen and I will open. I'm happy to answer any kind of questions that you have. And I don't know how quite that happens, Rebecca, maybe.
Yeah, hi, Carol. Thanks so much. I have to say, I was grinning, the biggest smile reading through or listening to you talk about some of the amazing responses that people had to being on safer supply. Really interesting. So yeah, folks, if you have a question, please put it in the Q&A box. There are a few questions here for you already, Carol. There's a question from Steve asking about capacity and why capacity of these programs is so low.
It was related to the funding that they received. So they would receive funding for so many slots and for so many other healthcare providers in the programs. And some of the prescribers also had other practices. So it was tied to the funding that they received.
Thank you. Someone else is asking about the points system and eligibility criteria. They say, to what extent is the points system eligibility criteria currently being used when onboarding new clients to Safe Supply? I was told the minimum criteria was using fentanyl at least 3 times a week.
So that I can't answer because, you know, our data are a little bit old, but there's probably someone out there who can answer that question. I don't know if someone wants to can they put that in the chat? Sorry, I don't
Yeah,
know the
people can
answer.
put that in the chat. I can also say that
Yep.
the criteria, you know, it is slightly changing in each program and site, responding to what's currently happening. And I think for a while, it's going to be an evolving thing as resources increase, decrease, as things and as programs get established. And one of the things is that, you know, as you said, Carol, it is very time consuming, very resource intensive work, particularly when somebody starts off at a program. And after a while, people sort of stabilize a bit. But when you start a new program, everyone is new. So lots and lots of big needs up front, and then things sort of settle down. But there will be some new guidance, another guidance document coming, an updated guidance document coming out shortly that will address this issue of program eligibility criteria. But it usually is triage criteria more than eligibility, really. Okay, Steve asks, how widespread is smoking or chasing the dragon?
That's a very good question. Some people talked about smoking, and I think definitely there are people on this call that can talk a lot about that. If anybody wants to put something in the chat about your experience of people injecting versus smoking and or swallowing medications, that probably is the best way to answer that question. So you got a contemporary answer. What is community medical care provider law enforcement reactions to Safe Supply? Can it be expanded? So I'll just talk a little bit about, very little bit about, nobody really talked to us about a lot of opposition to the programs from law enforcement at all. I don't know whether that's because law enforcement wasn't quite aware of them just yet in operation. They hadn't had problems that other programs like needle and syringe programs or supervised consumption sites have had in the past with police, you know, outside doing surveillance, or at least they didn't talk to us about that. And I think they probably would have if they actually had that experience. So that's about all I can say about that. Yeah. What the time of the, for how long had the participants been in the program? So the length of time in the program varied quite a bit, right? Some people we talked to, a small number who had been in for a month or so. And when we went to London, people had been in the program for a few years. Some were new or wherever, but that's a good point. We should probably add that in the future to our presentation. So there was variation from very new to had been in the program for a while. I'm just reading what Brett wrote. Brett's asking about the extensive primary care checkups really necessary. So a lot of people we talked to showed up once a week to talk to their prescriber. It was about a 15-minute appointment. When they initiate, there's more. So nobody complained. Like, okay. And so I've done studies with people on methadone in the past. And there were lots of complaints. The experience is different. So I don't know. And I'm reluctant to answer that question because it's a complicated question with yeah. I'm just going to say, so that's all I'm going to say about that. Sorry, Brett. I understand what you're getting at, but I'm not going to say any more about that. It's not my place to say anything about that for now. Did participants talk about issues with lack of desired drugs or dosages in Ontario? Yes. Some wanted patches and some, weren't too pleased. Some of the drugs were not available. Some they would like an injectable that's not a crushed, because these were all tablet based, right? And so yeah, there was some of that, not extensive, but we also didn't, to be honest, we didn't ask a lot about that. We did ask about how well their dosage met their needs, but we didn't ask extensively about the different formulations. Did your research touch on lateral violence and its impact on the staff? Do you mean by lateral violence in terms of from others in the community, or lateral violence within the program? So we did hear from some prescribers about how they were treated exceptionally badly by their colleagues, if that's what you mean, in the community, but not within the programs themselves. And there's some more dramatic examples of that than others. Were there any significant gender related issues? I don't know the answer to that yet. And yeah, I'm not sure that there's anything that really was striking per se, but we're still working on that. What do you think about the generalizability results in the need for a regulated supply of drugs for drug users who use drugs less regularly but still at risk of overdose, like your weekend warrior types? So to my knowledge, we didn't have any sort of weekend warriors in our sample that talked to these. The generalizability, well, it's a qualitative study, not to be cheeky about it. So there's, limits on the generalizability in general. I don't really see how that there would be a difference, right? For a weekend warrior versus someone using more frequently. In terms of outcomes, like if you're replacing the drugs for one and you replace the drugs for the other, the risk goes down, right? So, but that's kind of off the cuff kind of answer. So I haven't really thought about that all that deeply. What are the criminal justice ramifications if someone is caught with their safe supply on hand? Well, none, because they have a prescription. It's like any other medication. So there is no, they can be stopped, but they can't have their drugs seized because they're in a prescription bottle and they have a prescription. So there's none. Do I have diversion related findings? We haven't looked deeply into diversion. Yep, it occurs. The frequency with which it occurs is not clear to us. And some of it is related to diversion to friends and family who are also at high risk of overdose. There is some other kinds of diversion that we're trying to understand that isn't related to that, things happen. And also, we're not sure how long that persists, right? Maybe it's something that happens sooner when someone first gets in a program or not. But I will also say that the fentanyl that people are using now, for some, their tolerance is so high that it's really hard even for the safe supply medications to catch up with that level of tolerance. So I'm not dismissing diversion or concerns about it. I'm just saying it's a complicated thing that needs to be understood within the context of what's going on in the community. So don't think I'm being dismissive. Are you able to identify any major gaps in safe supply research? We need more longitudinal analysis. Like, that's just flat out. We need to understand, what happens over time, for absolutely sure. I think we also, I don't know, I haven't heard of anybody, doesn't mean they're not doing it, but I'm not sure that anybody's quantifying the impact on criminal justice in terms of frequency of exposure, and also doing some cost analyses as well. So that might be two areas that I might say are important. I do think, as related to the question, we need to understand more about gender, and also what the experience for racialized folks in these programs. I think this may have been mentioned at the beginning, so I apologize. However, how widely will these study results be shared, for example, with provincial, municipal? So we're in the process of we have a final report that we're finalizing, sorry about that. And we're also writing academic journals. We have 3 out for review. So yeah, when we'll send them to Rebecca when they're done, and they'll be as widely available as we can make them. What is the future of safe supply in Ontario? Good question, Steve Jones. I hope it can greatly be expanded as well. I think it depends a lot on how long Health Canada wants to fund the programs, and also how willing the province of Ontario may be to take on funding, and that's a question. So that's Rosie the Posy behind me. She likes to come to all my presentations. Someone wanted to know about my dog's name. And she also lives the dream, as you can see. So someone asked me about the participants were predominantly white. So to be honest, so Yvonne Chung asked me that. So we explicitly asked for help trying to recruit non-white participants. And so, programs helped, and people who wanted to talk to us could talk to us. I don't know about the, I can't tell you exactly how many participants were not white in the program. So that's one area that we didn't do as well as we had hoped. I will say we have a good number of people who identified as Indigenous who did want to talk to us and talked about their experiences. So it's not an all white sample, but people talk to us as they wanted to. And maybe, we need to either change who's doing the interviewing, how we're doing the interviews, or whatever in the future to get a better understanding of that. Are participants ever targeted? I think something I lost. Was there any interest for different program models in terms of roles of PUD in the program design and implementation? I'm not quite sure what that means, but I wonder if you're asking me, did some of the programs incorporate people with lived experience? And the answer would be yes. And so after that, I'm not quite sure how to answer that. People who regularly daily use, or there are people who regularly daily use other substances as well as, or did folks mostly use, so these programs were for people with opioid dependence. They may have been using other drugs, but a criteria was they had to have opioid dependence to get in. I don't have a goal of reduction, but is there any information on how long participants remain in the programs on average, and how long term use patterns? So the programs don't have a defined end. They're like methadone maintenance, right? People stay in the programs as long as they want, we hope, and perhaps as long as they are available. And I think that gets at my earlier comment about the need for longitudinal studies and prospective studies going forward, right? Like, what is the history of drug use for someone who's in a safer supply program, right? Like for some people, I'll just be honest with you, some people, they had zero interest when we talked to of stopping using drugs. They were quite happy with their safer supply. Well, they're more than happy, right, with their safe supply programs, because they weren't scared of dying, right? And some people were like, okay, so now I actually can see a different future for myself, and that's what I want. And I'm not going to say that one of those is better than the other outcome. It was like what people wanted at the time. And maybe that changes over time. I don't know, but it's worth, examining. Someone says criminal justice is an imperfect term. Criminal legal system is a bit better. Okay, thanks.
Carol, there's one other question I wanted to draw your attention to just a little further up. How did you define safer supply? And did that definition include oat? Is oat a subtype of safer supply, or is this a completely separate intervention? How can we differentiate within the literature?
Oh, so there's a whole article right now. I can't remember who the first author is, about trying to define. Do you remember that? It just came out.
We'll pull it up in a minute.
Okay.
We'll put it in the chat.
So we define safer supply as the prescription of dilaudid and sometimes with Cadian as what they would call the backbone to replace street-based drugs, right? Some people also got, not many, but some of them also got a prescription of methadone on top. Or in addition to, right? That's a really kind of contentious question if you want to know the truth. Is OAT a subtype of safer supply? I'd say no, and I'd say a lot of OAT prescribers would be not happy to hear that. But you have to think about the person in front of you and what they need and where they are in their journey. And also safer supply is new, and what it's going to look like next year, 5 years, and what methadone and Suboxone are going to look like in next year or 3 or 5 years, nobody really knows, because the street supply is changing, and how you respond to that is also changing in different kinds of modalities. So that's kind of a wishy-washy answer to say safe supply is one thing, but the definition's evolving.
I think that's a fair answer. I think one of the things it's a question that we often grapple with in a lot of our meetings and working groups and such, and thinking about the approach around safer supply, right? Around the way care is provided in terms of how what people's goals are, and really responding to what their goals are. And that is, for many people, being safe. Yeah.
So there's 2 last questions, one from Megan and one from Brett. So Megan asked, are participants ever targeted by other drug users wanting access to the safe supply who can't access the program? Yep, people did talk about that. Wasn't something we heard a lot about, but some people had some problems with that. Brett asks, did any participants report a change in their use of non-opioid drugs on the program? Yes, we did hear that. I can't quantify that for you in any way. And that would also be something that I'd want to understand over time. Like, do people stop using other things? Some people did tell us that. And some people said they were using other things just as much, but time will tell what that pattern is, right? And it'll depend on also people's goals over time, right? I think.
Sure. Oh, there's one more there from Terry. Do you have time to take that?
If you ask, what was it like for folks to talk to them? Okay, so yeah, so some people talked a lot about how I have a life now, right? My life is different. I'm not boosting, if that's a proper term, every day. I'm not doing some things, and people wouldn't define what some things were, right? Like, I'm not doing some of those things that I used to do anymore. They didn't want to talk about it. And they talked were talking to their children more. They had better relationships with their spouses, or they had a spouse or a partner. Some talked about not being ashamed anymore of their life in relation to their children. Some people didn't. They weren't reconnected, right? It wasn't the same for everybody, but some people had those experiences. And some people, we didn't ask, that's a very good question. Some people did tell us a little bit about, you know, now they could say that I'm on this program and this is a medication, and their families were more receptive to that than they had been in the past. And the extent to which that's going to happen, I don't know. But, you know, some people have really complicated lives. And you would hope that, you know, over time they become less complicated. But, you know, for some people, you know, safe supply will help with their lives, and some people maybe not so much, right? But time will tell, right? In that domain, right? Help in other ways, right? Yeah.
One of the things I've heard people talk about is time and how time changes for them when they start on safer supply. And so the importance of having other people to connect with, or groups to go to, things to go to. Did that stuff come up much in your?
Sorry, I was just looking at the question again. Can you ask
Oh,
me your question again? Sorry.
yeah, sure. Just about how people spend their time once they start on safer supply, because their days, you know, are no longer necessarily spent doing things like boosting and trying to find
Yeah.
when they're going to get their next dose and such, right?
Yeah. So we have some data about that. Definitely people said they had time for other things now, right? Like one guy I asked about, and he said, well, I could do what everybody does. I watch TV, I go and do my shopping, you know, I talk to my friends, I go to the movies, right? It's sort of like, why are you asking me that, lady? Right? Like, you know, like I just do things that I didn't, I couldn't do before, and now I'm just like anybody else, right? And you know, some people just had more stable, enjoyable lives, right? With less fear, which is
Powerful.
important, right? Boosting means stealing. Someone asked a question about boosting.
Very good. Carol, this has been fantastic. Thank you so much. I'm
You're
really
welcome.
excited.
My pleasure to be here.
I'm really excited about the publications coming out and the report coming out. This is the additional, you know, building the body of evidence for safer supply is so important. And I can already imagine all the different quotes and pieces that we'll be pulling out to support funding applications, program design and delivery, policy making, and all of that. So thank you so much.
You're welcome.
Really grateful. And I hope we'll be able to have you back as more findings emerge from your different studies.
Sure, me or someone else on the team. So yeah, we'll come back when we have more.
Okay, that's fantastic. And so what we'll be doing is we'll be posting this video of on our website. It'll be up. Usually it's up within a day or two at the most. When we do have those publications and such, we'll add those to that page, but also put them in our resource library. Yeah.
Great.
Okay. All right. And, thanks so much. Thanks to everybody who joined us today, and head on over to our website if you're looking to find out about our upcoming events and things like that for more information.
Thanks, Rebecca. See you.
Okay. Thank you.